Good morning, everyone. Now our instruction course is about the demystifying cases of neuro-ophthalmologic disorders. Changing, it's not changing. Okay. We know the visual pathway plays a very important role in diagnosing the neuro-ophthalmic disorder and neurological disorder. Hence, the knowledge of the neuroanatomy and neuroimaging will help us in understanding the pathogenesis of sign and symptom in these disorders. Common mistake sometimes made by an ophthalmologist is not to identifying the coexisting intracranial pathology in the case of cataract, because they try to correlate the visual loss with the presence of lenticular opacity. And one thing which we should keep all in mind, then in a mature cataract and how dense the cataract opacity would be, the pupillary reaction should always be normal, because the cataract is supposed to scatter the light inside the eye, and you know the pupillary reaction is proportional to the acting retina, means it stimulates the whole of the retina. Hence, though the light going inside is less, but as it is scattered and stimulate the whole of the retina, the pupillary reaction should always be normal. And once in the case of in our OPD, we get a case where we cannot explain the visual loss because we cannot explain by our ocular examination, that we label it as an unexplained visual loss, then always get the imaging done to find out any cause behind the eye. Sometimes the compressive lesion present along the path of third cranial nerve, they can cause the synkinetic movement of the third cranial nerve. When we get a case with binocular visual loss with normal pupillary reaction, then we should always think the cause would be either in the optic radiation or the cortical visual cortex. Sometimes we get the patient whose visual behavior is quite normal. You can see like he's moving around perfectly normally without hitting any object, but he can't read your Snellen chart, so you can't take the visual acuity. And he cannot, when you show some object visually, he cannot name the object. And even the patient fails to identify his familiar faces. Then, before thinking that these are the functional cases, we should think that the lesion might be in the visual associated area, not in the primary visual cortex, because the visual acuity, the form, the color, and the shape, you can perceive only, we perceive that primary visual things. Perception happens in the visual cortex. The further meaning to that object, what we are seeing, is that take place in the visual association areas in collaboration with the sensation from the sensory cortex. So we should get the imaging done in these cases to find out whether there is a cause with the bilateral. Usually it happens in the bilateral lesion of the visual associated cortex before labeling them as a functional visual loss, as a case of functional. So our instruction course would be a case-based approach to the various disorders affecting the visual afferent-efferent pathway and various neurovascular neuro-ophthalmological disorder. So I start with the cases. Can I have my second presentation, please? Second presentation. This is about a 30-year-old female. She came to our OPD with a history of holocranial headache for last 3 months, which was associated with transient visual obscuration lasting for a few seconds. And she also gave a history of recent gain in weight. This headache used to increase on the straining, like coughing, sneezing, and these attacks of transient visual obscuration used to happen whenever she would change her posture. This symptomatology will tell us that she must be having some intracranial pathology. Headache with visual problem, always it leads us to think that it must be intracranial pathology. When we examine the patient, the acuity and motility was normal, were normal. The fundi show a marked papilledema. Definitely the field will show enlargement of the blind spot. OCT will show the thickening of retinal nerve fiber layer, while rest of the systemic examination, including the neurological examination, was normal. So this is the patient presenting with increased intracranial pressure, with the features of increased intracranial pressure, with no neurological localizing sign and symptom. Then one diagnosis which should come in our mind is benign intracranial hypertension, which is also called as idiopathic intracranial hypertension or pseudotumor cerebri. Now, just to fulfill the modified Dandy criteria, then we should get imaging done to rule out any space-occupying lesion. So we got the imaging done. Another entity which can resemble with this type of presentation would be any tumor present inside the ventricle of the cranial cavity. So we got the imaging done. You can get even contrast CT or contrast MRI. It's better to get contrast MRI, which gives a more better detail of the brain. And we asked for MRA and MRV. And this image, when we got the imaging done, we found the features of idiopathic intracranial pressure in the form of empty cellular syndrome and dilatation of meningeal spaces around the optic nerve as shown by arrows. Now to make further, like once you get the imaging, normal imaging, the next step should be to find out the CSF pressure. And we have to get the CSF examined routinely, macroscopically. Even the culture should be done, because some of the cases of mild meningitis, tubercular, or fungal, they may mimic as idiopathic intracranial pressure. They can present clinically as idiopathic intracranial hypertension. So when we got the LP done, the opening pressure was high, more than 3 millimeters of mercury, and the CSF examination were normal. So on the basis of our clinical examination, investigation, we made a diagnosis of idiopathic intracranial hypertension. And she also gave a history of, she was a female, and she gave a history of recent gain in weight. So we asked her to do the weight loss done and restricted the sodium intake, gave her the Diamox. But she came after 6 weeks with further worsening of the symptoms and the fundus picture. We thought there must be another pathology. What we realized, what we asked them to do MRV and MRA, they were the conventional MRV which was done. I thought with such a severe papilledema, usually don't get in the case of idiopathic intracranial hypertension. Such a severe papilledema you get in the cases where there is a venous sinus block. Thinking that in my mind, I asked them to get the contrast MRV done. And now you can see the contrast MRV showed a tight narrowing at the junction of the dominant transverse sigmoid sinus junction with hypoplasia of the left transverse sinus. We know the left transverse sinus takes very little part in the venous drainage of the brain. It's a right venous sinus, which is a very important sinus, which drains most of the blood from venous blood from the brain. And you know, the most of the CSF is absorbed by arachnoid granulation present in the venous sinuses. So any blockage in the venous sinus will result in a marked increase in intracranial pressure with such a severe papilledema. Once you make this diagnosis, then what should be the next step? The next step to see whether this is a cause of IIH or it's an effect of IIH. So just to see the effect of IIH, this type of narrowing should disappear when you repeat MRV after the lumbar puncture. But this one was the persistent type of rigid, tight stenosis. And the second step would be to find out whether this narrowing is significant or not. Sometimes in IIH cases, you get the narrowing, but that is not significant. And for that, you have to measure the pressure proximal and distal to the stenosis with the help of this microcatheter. And the pressure, the difference in the pressure is more than 4, then you think it's a significant narrowing and needs to be taken care of. In our patient, the pressure gradient was more than 10 millimeters of mercury. Hence, we asked the neuroradiologist to do the angioplasty of the sinus, and they put the stent and there was a relief of the cisternosis with the proper drainage of the sinus. Venous return was resumed, and the patient became also asymptomatic in the follow-up. The second patient is about an 18-year-old male patient who presented with complaints of bilateral decrease in vision for 1 month. He gave a family history of decrease in vision on the maternal side. His maternal uncle also had a loss of vision at the same age. When we examined the patient, he had a severe visual decrease in the visual acuity. The color vision was impaired. The pupils were sluggish reacting to the light. Fundus showed, if you can appreciate, on the hyperemia of the disc, there were the dilated telangiectative blood vessels over the disc and in the pavillary area. And there was a mild blurring of the disc with temporal pallor. This type of fundus picture in a young male who had a family history, maternal side family history of visual loss. So we know this is a hereditary type of optic neuropathy. And which hereditary type of optic neuropathy? It would be a Leber's hereditary optic neuropathy, because it's a classical presentation of a Leber's hereditary optic neuropathy, where you get dilated telangiectated blood vessels over the disc in a male around the age of 10 to 30, between the age of 10 to 30 years, with a maternal family history of decrease in the vision. And the field examination in this patient showed dense central scotoma. We get the dense central scotoma in these cases because these are the macular retinal ganglion cells which are mainly affected in these cases. So the patient will have a central scotoma, cannot read, will not be able to identify the faces because of the central scotoma, but he would be able to move around because of the preserved peripheral field of vision. When you do FFA, and these discs, they also show a little bit of edema, which we call as a pseudoedema. But one very classical feature of the disease is, when you do the FA, you don't get the leakage of the dye in the late stage of FA, which should be there when you have a papilledema. So any patient, which I showed the clinical scenario, and when you find the fundus mild edematous disc with dilated telangiectatic blood vessels over the disc with marked decrease in the vision with a family history maternal side, decrease in the vision, and on an FA you don't get a leak, then you also get the confirmation this is a case of Leber's hereditary optic neuropathy. Now what should be the NAS investigation? The NAS investigation would be a genetic study, because we all know the cause of this optic neuropathy is the mitochondrial point mutation. When we got the genetic study done, we got the point mutation was 11778. And this is the commonest point mutation you get. And it has to find out the point mutation, it also helps us in telling about the visual prognosis in these cases. When this type of mutation is present, the patient will have a severe they have a very poor visual prognosis. They will end up with a marked loss of vision and even with the blindness. The treatment is coenzyme Q and analgesic. You know coenzyme Q is the complex one which takes place in the electron transmitter in the respiratory chain, which takes place in the mitochondria. It is a mitochondrial cytopathy. And the gene which I told you is responsible for encoding the complex 1 of the respiratory chain. And coenzyme Q is a synthetic derivative of that complex 1. That means it's a benzoquinone. And it's supposed to play an important role in preserving the vision and in some cases in increasing the vision in these patients. So our patient ended up with the 660 vision, and that's a stable vision on this treatment. Now about the third patient is a 14-year male patient who presented with transient visual obscuration in the right eye. So it's a young patient who had hemorrhagic phalanx in the right eye. When we examined the patient, his BP and the pulse were normal on the left side, but there was non-recordable pulse and BP on the right side. Neuro-ophthalmic examination was normal. So the two possibilities came in our mind, because looking at the age of the patient, it might be Takayasu or embolic phenomena. When we got the investigation done, we didn't find any cardiac cause of embolization, not any systemic cause of embolization. The CT angio of this patient showed there was a narrowing of the subclavian artery, and this narrowing was because of the presence of the cervical drape. And after the narrowing, there was a dilatation of the subclavian artery because of the presence of the thrombus inside it. But the pathology was happening in the subclavian artery, which doesn't take part in the blood supply of our eye. So what was the cause? It was a rare cause. We know the embolism can happen antegrade. But this hemorrhagic phagox was because of the retrograde R2 ART embolization from this thrombus which are present into the subclavian artery post-stenotically. And you know our common carotid artery and subclavian artery on the right side take origin from the same trunk, that brachiocephalic trunk. So the retrograde embolization happens from subclavian to the common carotid to internal carotid and ophthalmic artery, which resulted into hemorrhagic phagox. So beside the Takayasu, in the case of young, the cause of hemorrhagic phagox could be, which is a very rare cause, cervical drape. We should keep in our mind. So I will request the next presenter to present his cases.
Good morning to all. I'm Dr. Vikas Kanaujia. I'm at PGI Lucknow. I'm an additional professor over there. So after such wonderful presentation, my cases are very simple. These are certain vascular anomalies which I'm going to present. Only 2 cases. I think those who are stalwarts in neuro-ophthalmology sitting over here, they are having a very good idea what I'm going to present from the very beginning of my slide. But for the PGs who are sitting over here, they would find it something interesting and they should know. This case presented to us in our OPD maybe 3 days back when we came to this conference. It was a 52-year-old male who developed sudden headache 4 months back before coming to our OPD, and that headache subsided in 10 to 15 days with some medications. Then after 2 months of that headache, he noticed a redness of his left eye, as you can see from this picture, and for last 15 days he was having swelling which has gradually increased to the present size with the chemosis and everything. And there was a gradual decrease in vision for last 2 years in his both eyes, for which he got his right eye cataract surgery done, and the left eye is still having cataract. That is advanced immature cataract, almost on the verge of a maturation. And there was no history of, as per the disease is concerned, we asked certain questions regarding dryness, itchiness, earlier something was like that or not, grittiness of the eyes in the past, trauma to head, any hypertension or diabetes mellitus, connective tissue disorders or collagen vascular disorders. But all they were negative. On examination, visual acuity, as you can see, was 612 in the right eye and finger count 1 meter in the left eye, maybe because of the cataract. And conjunctival injection, chemosis, cork screening of episcleral vessels, IOP was found to be raised. His right eye is pseudophakic, as I told you, and advanced IMSC in the left eye. Fundus right eye normal and left eye could not be visualized because of the cataract. Extraocular movement, you can see over here that definitely there is restrictions in all the gauges. This is a second female which came to us maybe 2 years back. She was a hypertensive female. She came to us with redness for 5 months in the right eye and diplopia on seeing extreme right for 15 days. That means that redness was for 5 months, and diplopia suddenly she developed for 15 days back. This is the extraocular movement. As you can see, this abduction deficit on the right side. And now the other extraocular movements, they are normal. Apart from this, the conjunctival injection and the prominent episcleral vessel. You can see from here, the episcleral vessels, they were prominent. And this was her fundus picture. This is the right eye. You can see the venous tortuosity and dilatation in the right eye. The left eye is normal. Now, what could be the probable diagnosis? If any PG is having any idea, what could be the probable diagnosis by these 2 cases? Yeah? Pseudotumor. Okay. Any other? Okay, fine. So, apart from dry eye, allergic conjunctivitis, other causes of redness, the local causes. These are the other causes that can come to your mind with such a red eye if those local causes, they are found to be negative. And herpes, fungal or fungal orbital or cavernous sinus infection, lymphoma, but age group lymphoma can be there. Now this is CCF, low or high flow cavernous sinus thrombosis, but that would present mainly with the both eyes, giant cell arteritis, orbital ischemic syndrome. The female at that age, you can see the female was having something congestion. So this is the picture of the female, the CT scan picture of the female, and you can see over here there is some fullness in the cavernous sinus area. This is a base of a skull photograph seen from above. This is the cavernous sinus. This is the cavernous sinus opened up. You can see the ICA, that is the internal carotid artery, going through that. So for this, the MRI was done 3 days back, and it was done by the radiologist, and they found something interesting in this case, because no other finding was there. They found it this over here and this over here. So apart from this left extraocular muscles, they were found to be bulky, and there was some fat straddling over there, standing over there. Now a DSA is digital subtraction angiography. It is basically at your X-ray investigation. You give so many serial X-ray exposure to the patient, and you subtract the skull from that. That is the region. It is called digital subtraction angiography. And you can see over here, this is the pictorial diagram of the ICA, and you can see over here, this is the common carotid ICA going into this is a siphon of the ICA, and this is ACA and MCA. MCA is middle cerebral artery and ACA is anterior cerebral artery. So ICA just terminate as MCA. Now you can see over here, this is the internal carotid artery. This is a DSA. You go directly through femoral artery or femoral vein. While doing a DSA, it depends from where you want to go. If you want to go to internal carotid artery, you go through your femoral artery. You go over here through the heart, through that your subclavian and everything, common carotid. Now you inject the dye from here or from here. This is, you can see the catheter is there lying over here, and you can see the blush in the internal carotid artery area. And they also perform this digital subtraction angiography by putting the catheter into the ECA, that is external carotid artery. So again they found some blush. These are the branches of external carotid artery, the superficial temporal artery, and this, you can see this middle meningeal artery, the branch of that your external carotid artery. So again they found some blush, and this is what is the pictorial diagram, the external carotid artery. These are the branches all. These are all branches, the middle meningeal artery, you can see over here, a branch of external carotid artery. This is a DSA seen from behind. From here, you can see, now this is the venous phase of that DSA. This is a venous phase, that means venous phase has started, and you can see over here the dye is now coming into the cavernous, this venous sinuses. This is your, what the madam has shown earlier, this is the transverse sinus and this is the sigmoid sinus. Okay, so again the communication with the external carotid artery, branches, meningeal branches. And this is the transverse sinus. This is again the pictorial diagram for the PGs only. This is your superior sagittal sinus, the transverse sinus. You can see some part of dye is visible in this superior sagittal sinus, and this is the transverse in the sigmoid sinus. So the diagnosis was carotid cavernous fistula. The first patient is awaiting that intervention. Radiologists want to do something with that, which I will tell you later on. And this is the first patient, the second patient, the female, in which I showed you that some fullness of the carotid, that your cavernous sinus area. This is the coiling of that fistula was done because these are the external carotid artery meningeal branches. These are very small branches. So attempting any coiling from the smaller branches, it's very difficult. So they go through the venous route. That means this, you can see the external carotid artery, this internal carotid artery, and this is the IJV. IJV is internal jugular vein. So you have to go through IJV, that is internal jugular vein, and then to inferior petrosal sinus, to cavernous sinus, and there from cavernous sinus you do that your coiling. And this is the photograph of that female. Now you can see the improvement in the abduction. Okay, the congestion has gone. This is the pre-op and this is the post-op. Now, another case, I think this diagnosis is very much clear. This patient was having trauma. He came to us in May 2008 with complaints of this all complaints. Okay, MRI was advised, but he left against medical advice. He was not having that much amount of money, so he left. And then after 9 months, he came to us again with this much of picture: keratinization, severe chemosis, fullness over here in the supraorbital area. So very much clear it was a history of trauma. So it was a case of direct CCF. Now you can see over here, which I showed you in the first case, the radiologist pick up something, that hockey stick sign. This hockey stick sign is because of this superior ophthalmic vein. This is the superior ophthalmic vein runs from lateral to medial side, and you can see over here, lateral to medial side, it gets enlarged in CCF. Okay, direct CCF, because lot of drainages it is getting from the cavernous sinus. So, and this is the DSA, this is the enlarged superior ophthalmic vein. And this is after that your endovascular coiling, and this is maybe 3 months after that the procedure was done. So classification CCF are classified as a direct CCF and indirect. Indirect, they are having the communication from the smaller that arteries, that is the meningeal branches of external carotid and internal carotid, and direct is having a communication with the internal carotid artery. That means cavernous sinus is having a communication with the internal carotid artery. This is the cavernous sinus, this is going through. If it ruptures, what will happen to this? The whole of the flow from the internal carotid artery will go into this. And this is the indirect. And classification, traumatic and spontaneous. This is for the direct one. Traumatic is from trauma, and direct is spontaneous rupture of atherosclerotic arteries in elderly females or males. And these are the presentation for the direct CCF, and these are in the indirect CCF. The important point is patient may come to you with mild congestion for long and with corkscrewing of episcleral vessels. So my take-home message is cases of chronic conjunctival congestion with chemosis, with his previous history of trauma may be there, whooshing sound and pulsatile proptosis. It may be there in low flow fistula also, but not many a times. So these cases may present initially to the ophthalmologist, and careful and prompt suspicion by ophthalmologist is absolute necessary. In these cases, associated visual impairment and ocular conditions such as glaucoma should be identified, because many of these patients, they may be having increased IOP because of the raised pressure in episcleral veins. And the ophthalmologist should be able to order the appropriate test, that, as the madam told you, the magnetic resonance venography with contrast, or MRA. That means magnetic resonance angiography with contrast. So prompt referral to neuroradiologist saves many complications because they would intervene in time. And in addition to, ophthalmologist should be able to monitor the case. Not only that the intervention radiologists have done his part, you have to monitor the patient for the IOP, okay, and for the fundus finding and everything. Now, I would invite Dr. VAIBHAV Jain. He would present certain set of cases with the visual pathway dysfunction.
Thank you so much. Good morning to all of you. I will be presenting the cases with compressive lesions of visual pathways. So there are just 4 cases. So they have presented to ophthalmology department with various presentations. So our first case was there was metastasis of breast cancer to the intracranial part of optic nerve. So a 50-year-old female who was a known case of breast cancer complained of painless progressive loss of vision in the left eye for 1 week. So on ocular examination, there was no perception of light in the left eye, and there was afferent pupillary defect in the left eye. Right eye was absolutely normal, and fundus was also normal. Visual field was normal in the right eye, and on systemic examination there was malignant ascites because of metastasis of breast cancer, hepatomegaly, and rest of the neurological examination was normal. So differential came in mind. Probably there is a compressive lesions of somewhere in the optic pathways due to metastasis, but the site of metastasis we have to find out. And another presentation is retrobulbar optic neuritis can also present with the same feature with normal fundus and loss of vision. And next question was, where is the lesion? So as there is no optic disc edema and hemorrhage, so there was no metastasis directly to the optic nerve, and there was also no visual defect in the other eye, so optic chiasma was also not involved probably. So imaging must be done in these kind of cases. So MRI finally gave the answer. So this is a sagittal section contrast enhanced MRI showing contrast enhancing lesion near the convexity of frontal lobe. So as we can see, here is the metastasis to the frontal lobe, and this is the perilesional edema we can see here. And this is an axial scan again showing the lesion near the convexity of frontal lobe with perilesional edema extending to the medial part of frontal lobe. Again MRI axial showing the extension of edema to the gyrus recti. Gyrus recti is the medial most part of frontal lobe here. And this section again shows the edema extending to the basifrontal area which lies just above the intracranial part of optic nerve. So the frontal lobe tumor in the anterior part that creates the perilesional edema and the herniation of gyrus recti causing the compression of intracranial part of optic nerve that is near the chiasma. So though the lesion is far away from the optic nerve, but the edema extending to the gyrus recti causing its herniation and compression of intracranial part of optic nerve, which could be explained by radiology and anatomy of the site. So as we can see here, here is the gyrus rectus, and this part is herniated, and this is the intracranial part of optic nerve that is compressing here. So that is finally causing the loss of vision in the left eye. So this is again radioanatomical correlation. So here we can see the herniation of gyrus recti, and here this is the intracranial part of optic nerve getting compressed with the herniation of gyrus rectus. So the monocular vision loss with normal fundus and afferent pupillary defect in a known case of breast cancer. So there was a clinical suspicion of metastasis. So clinical history and anatomical knowledge of surrounding structure is the key for diagnosis of such cases. Case 2 is atypical optic neuropathy due to pituitary apoplexy. The 40-year-old female presented with sudden diminution of vision left eye for 2 weeks. There was similar episode occurred in the other eye a year back. She was treated with oral steroid after making diagnosis of optic neuritis. Every time her vision improves from 6/60 to 6/6. There was no associated feature, and ocular examination color vision was impaired and pupils were sluggishly reactive. On fundus there was mild temporal disc pallor, and on visual field we can see here there was a right field normal, left temporal hemianopia with central scotoma. So our clinical diagnosis was there was atypical optic neuritis left eye because it was painless in nature and it was steroid dependent, and because it is improving within a week of steroid treatment. So MRI brain was done, and we can see a large cellular mass here, a large cellular mass with central liquefaction extending to the supracellular region with peripheral enhancement. So optic chiasma is displaced superiorly. So this is a case of pituitary apoplexy presenting with sudden onset of painless unilateral visual loss. Pituitary apoplexy is a sudden hemorrhage or necrosis inside the pituitary tumor resulting in sudden enlargement, which clinically presents as sudden bilateral visual loss or field defect, along with ophthalmoplegia and headache. So ophthalmologist perspective, there was a sudden onset of visual loss. So that can be a sole presentation of pituitary apoplexy without other features. Recurrent pituitary apoplexy which resolved on steroid with release of compression of chiasma. So imaging must be done in these cases. Case 3 was painful third nerve palsy due to paracellular extension of pituitary adenoma. So a 25-year-old female presented with sudden onset of severe supraorbital pain on the left side with double vision and drooping of left eyelid for last 5 days. There was similar episode twice before and symptom resolved again with oral steroid. So she was diagnosed as Tolosa-Hunt syndrome elsewhere. And there was, on systemic history, there was menstrual irregularity off and on for last 4 years. She was non-diabetic and non-hypertensive. So on ocular examination, she presented with the features of third nerve palsy in the left eye. And fundus was normal, fields were normal. So clinical impression was painful left oculomotor nerve palsy with normal visual fields. So MRI brain was done, and here we can see a cellar mass with paracellular extension. This mass is extending in the paracellular area. So in the paracellular extension on the left side is more extensive, shows encasement of left internal carotid artery. So probable diagnosis was a case of pituitary adenoma presenting as painful third nerve palsy. So why third nerve palsy? Third nerve is frequently affected because it penetrates the roof of cavernous sinus lateral to the posterior clinoid process, then comes to lie superiorly in the wall of lateral cavernous sinus. Hence, it is the closest nerve to the sellar area here. So this case showed the isolated painful third nerve palsy can be the sole presentation of pituitary adenoma without any visual and field defect. So hence it should be included in the differential diagnosis. Case 4 was a 25-year-old male presented with complaint of dull right periorbital pain on eating food for last 3 months. So there was pain lasted for 10 to 15 minutes and then it subsided by its own. There was no other history. And the ocular examination was absolutely normal, but in visual field defect we saw the bitemporal superior quadrant enopia. So as we all know, that is the representative of chiasmal compression. So MRI brain was done and we can see cellar mass with supracellar and right paracellular extension that is encasing internal carotid artery. So the trigeminal nerve was involved. So probable diagnosis was pituitary adenoma presenting as atypical trigeminal neuralgia. So this case represents as the sole presentation of pituitary tumor involving chiasma. Visual field and MRI played a key role in the diagnosis. Thank you so much.
Can I ask one question for this? Breast carcinoma, no, you should focus on the optic nerve, leptomeningeal area, where no, the thickening can be, you get, particularly for the breast cancer.
Sir, we have to localize the lesion. So we have to tell the radiologist about the probable site of lesion because normally it is not well localized, the herniation.
so won't subject the patient for a further investigation for the monocular visual loss. That's the thing. I would be presenting a case of retrogeniculate pathway pathology, and it's mainly for the PG because most of the neuro-ophthalmologists would be knowing about it. So this is a known hypertensive patient who was referred to us from cardiology department because he lost his vision suddenly in both eyes after the coronary angiography. So when we examined the patient, he had a profound visual loss. He could not make out the difference between the light and the darkness. And on the there was no reflex blinking of the eyes on exposure to the bright light or threatening stimulus, that is Meniere's reflex was absent. The rest of the ophthalmic examination was normal. But after some time, after a few days, the patient started regaining the vision. Now, as we know, this is a case with sudden transient bilateral visual loss after the coronary angiography with normal ocular examination. We know the pathology must be behind the lateral geniculate nucleus because the pupillary fibers, they leave the optic tract before the lateral geniculate nucleus, so they are preserved. That's why the pupillary reaction was normal. And fundus picture would definitely be normal because it was behind the geniculate ganglion, so there is no transsynaptic extension of degeneration to the anterior visual pathway. Then before labeling these type of cases, because we think that the patient has sudden visual loss, such a marked loss, but our ocular examination is normal, the first thing will come in our mind might be a functional visual loss. So confirming that functional visual, these are two pathology in that clinical scenario, these are the two diagnoses which should come our mind. And to now substantiate these diagnoses, the next would be a mirror test and opticokinetic nystagmus. We know in a functional visual loss, patient cannot suppress his movement when you move the mirror in front of him or do the opticokinetic nystagmus. But in our patient didn't show any movement of the eye on both these tests that confirm that he has really some organic pathology, and that's a cortical visual loss. But patient of ours showed a normal MRI. But the presence of normal MRI doesn't rule out the possibility of cortical visual loss. But this is another MRI of another patient of ours who also presented to us with a profound visual loss, but he didn't recover the vision, and that he resulted into a permanent, he ended up with a permanent visual loss. And you can see that CT of this patient, there is a bilateral cortical infarct, and this is very rare presentation of this case. This is a very rare presentation of a case because bilateral occipital infarct because of the closure of the branches of the posterior cerebral artery is quite a rare phenomena. But this most possibly what happens in these cases, he must have had a occlusion of one of the branch of posterior ciliary artery supplying to the visual cortex quite way back. And that must have resulted into a contralateral homonymous anopia, for about which he was very much unaware or didn't notice that. When he had another attack of occlusion of the posterior cerebral artery territory, which was normal on the previous attack, now he had another attack of embolization into the posterior cerebral artery that resulted into the homonymous anopia on the other side. So the patient now this time interpreted it as sudden bilateral visual loss. Sudden bilateral visual loss most commonly can be seen when they receive hypotension. And our patient, after a few days, we did the VER, that all was normal. So even that you get the normal MRI, normal VER, do not rule the possibility of cortical visual loss, because the patient can show sometime the normal VER recording, because when you see From our retina, the visual pathways, most of the fiber, they go to lateral geniculate. From lateral geniculate, they go to our visual cortex, the primary visual cortex, V1 area. Some of the fibers, they bypass this primary visual cortex. They go to pulvinar, from pulvinar to the visual association area, V2, V3, V4, V5. Or some of them, they go to the superior colliculus. From there, they go to the visual association areas. So they say sometime, these 5 visual fibers, which are in the visual association areas, they may produce the normal VER response in this patient, or sometime this infarct in the visual cortex is a patchy infarct. So there are some neurons which are still functioning, and they may give you a normal response in this patient. So it's very important to know that sometime when you see the visual behavior of the patient is like that, he or she is not seeing, like colliding to the objects around, and the VER and MRI, you get it done, they are normal, then you still think of the possibility he might be having a cortical visual loss, and do the mirror test and OKN test to rule out the functional visual loss. So this is a case of cortical visual loss or impairment, we say, because some of these patients where the insult is transient, they may recover vision. So they say now, rather than calling them a cortical visual loss, call them a cortical visual impairment. And in our case, the cause was a transient spasm of one of the branch of the posterior cerebral artery bilaterally. So a few words about what is a cortical visual loss for the postgraduate. It is caused by lesion of both the sides of optic radiation or to both the sides visual cortex. And it may result into a temporary, depending upon the insult, or it may result into permanent visual loss. The visual loss may last from minutes to days according to etiology, and it should always be bilateral and symmetric. And the visual loss may vary from no light perception to some vision in both the eye. And the patient would not respond when you show a threatening strong light, would not show a reflex blinking of the lids. And this is what I was telling, why the pupillary reaction is normal, because you know they leave the optic tract before the pathway optic tract enters into the lateral geniculate body into pretactal nuclei. So these fibers are preserved, and the pathology in our case of cortical visual loss is either on both the side of these optic radiation or into the primary visual cortex of both the sides. So ocular examination was perfectly normal. VER response, as I told, may or may not be present, but most of the cases it is not present. But some of the cases it may be present. Imaging, most of the cases have normal, show some pathology. Some cases may be normal. And it's important, like in the children, we get sometimes consultation, a preterm child or a baby is brought into the OPD with a complaint that mother says the child is not fixing, not following, and not showing any visual response. That means in these patients, when we ask them, then we always find there's a history of perinatal birth asphyxia, and then hypoxia is the commonest cause of the visual loss in this patient. Or sometimes they have a mixed loss. Along with the cortical visual loss, they have an optic atrophy also, depending upon how long the hypoxia period was there. And the pupillary response definitely in children, if we assess, would be normal. And these children, the commonest pathway which is involved, not the visual cortex, in the preterm children is this optic radiation, which presents on imaging as a periventricular leukoencephalopathy, periventricular leukodystrophy. Or if the patient comes very late, then it would be periventricular leukomalacia with a dilatation of the lateral ventricles. So the commonest cause of this cortical visual loss is a hypoxia in the children, ischemia or cardiac or respiratory arrest in the adults, and hypotension is another very common cause, but it has to be quite severe hypotension. A hypertensive crisis or a metabolic cause like hepatic encephalopathy or a status epilepticus, like we know always in the ictus there is a wave of excitation followed by a wave of depression, and that is called ictal emerosis. But these are the transient visual loss in the case of ictal emerosis.
Good morning, everyone. Today I will be talking about the oculomotor nerves, the third, fourth, and the sixth cranial nerves, and some interesting cases in relation to these nerves. The first case is a 60-year-old male patient who presented with bilateral drooping of eyelids for 4 days. He was a known diabetic and hypertensive. On examination, the visual acuity in the right eye was normal. In the left eye, it was 612, which improved to 6.6 with pinhole. The patient had bilateral ptosis. There was restriction in elevation of the right eye and restriction in elevation, depression, and adduction of the left eye. And the left eye was abducted. The pupil in the left eye was dilated and not reacting to light or near. As we can see here, there is restriction in elevation of both eyes. The left eye was abducted with a dilated pupil, and there is also restriction in adduction, depression, and elevation in the left eye. So all other examinations and systemic examination were within normal limits. So this clinical picture is very typical of a nuclear third nerve palsy, as there was unilateral complete third nerve involvement with bilateral ptosis and contralateral superior rectus involvement. The laboratory parameters in this patient were within normal limits, and MRI was done. This is a DWI image which shows a small hyperintense lesion ventral to the cerebral aqueduct in the midbrain, now which was suggestive of an infarct in the region of the third nerve nucleus. Now, correlating it anatomically, we can see the location of the oculomotor nucleus, which lies ventral in the periaqueductal gray matter, ventral to the cerebral aqueduct at the level of the superior colliculus. Now, a little bit about the anatomy of the third nerve nuclei. The third nerve nuclei consists of 4 paired nuclei and a single dorsal caudal nucleus, which supplies the bilateral levator palpebrae superioris. The paired nuclei supply the inferior rectus, medial rectus, inferior oblique, and the contralateral superior rectus muscles. As we can see here, the central caudal nucleus, which supplies the bilateral LPS, lies in the caudal part of the third nerve nucleus. So lesions which are rostral in location might very well spare the LPS action of both sides. The superior rectus subnucleus lies in the medial part, and it supplies the contralateral superior rectus muscle, the fibers of which pass through the ipsilateral subnucleus without synapse and supply the contralateral superior rectus muscle. The inferior oblique subnuclei is located in between the inferior rectus and the medial rectus subnuclei. Now coming to the next case, a 25-year-old female presented with complaints of double vision, headache for 2 months. She was non-hypertensive, non-diabetic, and did not have any other systemic complaints. On examination, the right eye vision was normal for distance, whereas the near vision was N36, which improved to N6 with a +1 diopter sphere. The left eye vision was normal. On examination, the right eye was found to be hyperdeviated, which the hyperdeviation increased on right gaze and left head tilt, which was suggestive of an inferior rectus palsy of the right side. The pupil in the right eye was slightly larger than the left and was sluggishly reacting to light and near. As we can see here, the right eye is hyperdeviated, and the hyperdeviation increased in the right gaze. The fundus and fields for the patient was normal, and a clinical diagnosis of a right inferior rectus palsy with minimal involvement of the right pupil was made. The hemogram and the vasculitis profile were within normal limits, and MRI was done for the patient, which showed a ring-enhancing lesion in the ventral part of the tegmentum of the midbrain near the midline with perilesional edema, which was suggestive of a tuberculoma of the midbrain. Now we can see this is the typical fascicular arrangement of the third nerve. In this case, the medialmost fascicles are those affecting the pupil and the inferior rectus. So in this case, we can localize the lesion to affecting these fascicles to be present over here, which involve the pupil and the inferior rectus muscles. The patient was started on antitubercular therapy. The double vision pupillary asymmetry resolved completely, whereas accommodation resolved partially. So the idea of presenting this case is that fascicular involvement of the third nerve may present as an isolated muscle involvement without any other neurological signs or symptoms. Now coming to the next case, a 22-year-old female presented with drooping of the left eyelid for 1 day. She gave a history of fever with rigor, holocranial headache, pain in the neck, photophobia, and a history of upper respiratory tract infection. This symptomatology was suggestive of an episode of meningitis. Vision in both eyes was normal, and on examination there was a complete third nerve palsy in the left eye. All other neurological examinations were normal. So a diagnosis of a left third nerve palsy was made due to viral meningitis. An MRI was done which showed a thickening and enhancement of the subarachnoid part of the third nerve. The third nerve palsy resolved completely in 4 months, and this case gives us an idea that apart from the normal causes of involvement of the subarachnoid of the third nerve in the subarachnoid part, like tumor, aneurysms, and vasculopathic disorders like diabetes and hypertension, meningitis can also present as a third nerve palsy due to neuritis affecting the subarachnoid part of the nerve. As we all know, the pupillary fibers lie in the superficial part of the nerve, so aneurysms compressing the nerve affect the pupillary fibers and present as a painful pupil involving third nerve palsy, whereas vasculopathic conditions affect the deeper vasculature of the nerve, the vasa nervorum, and present as a pupil sparing third nerve palsy. We can see here the close proximity of the posterior communicating artery with the third nerve, and we can easily understand any aneurysm involving the posterior communicating artery may affect the third nerve. Now coming to the next case, a 19-year-old female presented with complaints of drooping of left eyelid for 1 month. Vision was normal in both eyes. There was minimal restriction in movement on adduction and elevation. Abduction and depression were normal. There was partial ptosis on the left side, and on depression, elevation, and adduction of the left eye, there was retraction of the left lid. All other examinations were within normal limits. We can see here partial ptosis in the left eye, and there was lid retraction on down gaze, adduction, and an up gaze. So a clinical diagnosis of a primary aberrant regeneration of the third nerve was made. An MRI was done which showed a lesion anterior to the midbrain and pons, mainly on the left side, compressing the subarachnoid part of the third nerve and brainstem, which was suggestive of an epidermoid in the pre-mesencephalic cistern. So the idea of presenting this case is that compressive lesions may affect the third nerve and present solely as a primary aberrant regeneration of the nerve without any other neurological signs and symptoms. Now coming to the last case, a 50-year-old male patient presented with a sudden onset of vertical double vision with mild uneasiness in the head at the onset of the double vision for 1 week. He was a known hypertensive, non-diabetic, and had no other complaints. Now on examination, the vision was normal in both eyes. There was right hyperdeviation which increased on left gaze and right head tilt, which was suggestive of a right fourth nerve palsy. This, why we say so is we can understand by the Bielczewski 3-step test. So this is a schematic representation of the test. In this patient, there is a right hyperdeviation. So it isolates the involvement of the 4 nerves, that is the depressors of the right eye and the elevators of the left eye. Now in the next step, the hyperdeviation increased on the left gaze. So we can isolate 2 nerves which act in the left gaze, 1 in each eye, that is the superior oblique in the right eye and the superior rectus in the left eye. Now the third step is the head tilt test. On tilting the head to the right side, the hyperdeviation increased in this patient. So on right tilt, there is intorsion of the right eye and extorsion of the left eye. And also in normal circumstances, the elevation action of the superior rectus is counterbalanced by the depression action of the superior oblique muscle. In this case, as it is superior oblique palsy, the superior rectus has an unopposed action which causes the hyperdeviation in that eye. On double Maddox rod test, as the right eye was hyperdeviated, the patient could see the red line which corresponds to the right eye to be lying below that corresponding to the left eye. And then the patient was asked to rotate the Maddox rod till the 2 lines became parallel to each other, and the amount of rotation gave us the amount of extortion present. An MRI was done, and the MRI revealed dilated draining veins in the right ambient cistern, as we can see here. So this was a case of 4th nerve palsy due to right perimesencephalic dural AVM. Anatomically, we can see the 4th nerve which exits from the dorsal part of the midbrain posterior to the inferior colliculus and then proceeds rostrally. So we know the common causes of fourth nerve affection are trauma. So this is just an uncommon cause which led to a fourth nerve palsy. So that's all about the oculomotor nerves. Thank you so much.
Suppose a sarcoid or a TB infection. Yeah, if you have a pachymeningitis on treatment, the thickness reduces, or
Pardon?
If there is a treatment for tuberculosis with pachymeningitis, if you treat them, the sizes or the dimension it decreases down the line or anything? You correlate with the meningeal involvement?
You know what happens in this, the improvement is never complete, what I have seen. Imaging finding, I can't tell you on the follow-up, but the ophthalmic finding, I can tell you, they don't have a complete improvement in their oculomotility, and sometimes they have a recurrent attacks.
Thank you.
Now.
Thank you very much, madam. You have taken a fantastic class today.
Okay, thank you.
And I'm a retired professor from Coimbatore Medical College.
Okay.
Coimbatore Medical College. I'm a retired professor
Okay.
of ophthalmology. But as doctor told me, I have forgotten your name, sorry. But he told now about optic neuritis and all. And he found out pituitary apoplexy.
Dr.VAIBHAV or Dr.VAIBHAV? Yeah.
Or pituitary apoplexy.
Yeah.
So I feel, no, is it always must to do MRI for all cases of optic neuritis before starting ONTT or something like that regimen?
It's
I want to know.
In atypical presentation, the MRI must be done to rule out any intracranial cause. So,
Because we had one similar case about 20 years back. That time we had I have given the dissertation to the student. We diagnosed as optic neuritis, and we are giving same treatment, ONTT as per trial. Then afterwards, it improved and again came back, as you said. Then we did the MRI or something. Then we found out the pituitary problems. That's why I made it a point always to take MRI before starting any ONTT, also, so that we can rule out whether a pituitary lesion is there or not. And moreover, they will respond to steroids also. That's a problem. Even pituitary tumors, they can also respond because of swelling and all can subside with steroids.
yes, they respond.
And that's why I feel it's a must for starting any optic neuritis, MRI.
MRI will help us even in the cases of typical optic neuritis, because of demyelination to prognosticate whether the patient how much risk he has to later on to develop MS. So that is, getting the MRI will not be any problem. It should not be a question, we can do it,
Yes.
no problem.
Very nicely, madam. Thank you.
Thank you. Now we have Dr. McIntosh. Is he here around? Oh, sorry. I'm sorry. Dr. McIntosh is from Iowa University. He's a very well-known neuro-ophthalmologist in USA. And he's one of the principal investigator in Quark study about anion. He's going to tell us about what is an anion and what is about this. And he's going to give us a brief introduction about this trial also. What is this trial? And what product is being used.
Thank you for the nice introduction, and thank you for inviting me to speak here at your conference. Non-arteritic anterior ischemic optic neuropathy, or NAION. As many of you know, it's the most common cause of unilateral optic neuropathy in older adults, and there's a number of important risk factors that we all ask these patients when they present with these kinds of problems. Most of these relate to vasculopathic risk factors, nocturnal hypotension, and also this disc at risk, which you can see here. This is the normal disc, normal size with a cup, and on the disc at risk, the disc is smaller and that crowds the axons as they go through the optic nerve head. A lot of the information that we know about the demographics of ischemic optic neuropathy come from the ischemic optic neuropathy decompression trial, which was a multi-center study that was conducted in the United States in the 1990s, randomized, sponsored by the NEI, and it aimed to observe patients for about 2 years. One group observation and the other group receiving optic nerve decompression. This study provided important natural history about NAION. It was large and prospective, and had a standardized definition for NAION and evaluated patients within 2 weeks of symptom onset. But are patients here in India the same as the patients in the United States? Maybe in some ways. An interesting study published just a couple of years ago by Saxena actually looked at this. And although it was a small study, only 40 patients, it was case controlled, and the patients presented within 1 month of symptom onset as opposed to the 2 weeks in the decompression study. They were followed for 3 months, so not as long as the decompression study, but still it provided important baseline characteristics that we can try to compare to see our NAION patients here the same as those that are described in the decompression study. There's been a lot of studies that have looked at ischemic optic neuropathy over the years, and here's the Indian study. And what you'll see is that there's a number of things that are actually similar. The male to female ratio is always somewhere between sort of 0.5 and 0.6. The rates of hypertension and diabetes, these vasculopathic risk factors, are also similar. But one interesting differentiation is the age. And that's one thing that was actually mentioned, is that the patients in India are perhaps a little bit younger than the patients that are presenting in the West. Does this have to do with earlier onset of hypertension and diabetes? We don't know, but that is one interesting finding that came out of that study. We know, however, that regardless of where these patients are, they present with painless vision loss, usually upon awakening, related to nocturnal hypotension. The decompression study looked at the vision, the presenting vision of these patients, and found that a lot of these patients actually present with reasonable vision, greater than 20/60 or 6/19. The Saxena study looked at vision, measured vision a little bit differently, and instead provided a median baseline visual acuity that was 20/630 or 6/190, which in some ways sounds worse, but again, it's difficult to compare because it was presented in a different way. The decompression study looked at the mean deviation, which was about minus 18.6, and the Saxena study looked at the most common visual field defect, which was infranasal, and that's consistent with a lot of other studies that have been published. These are the classic findings that we look for in ischemic optic neuropathy. Initially, patients might have some mild disc edema, segmental swelling with splinter hemorrhages, various located cotton wool spots, as well as dilated capillaries. The superior segmental swelling eventually will progress to atrophy, and here that swelling led to superior atrophy, which corresponds to the classical inferior altitudinal defect that we talk about in ION. Quick word about Pseudo-Foster-Kennedy, which is a syndrome where there's an old incidence of ischemic optic neuropathy resulting in optic nerve pallor, and then an acute event in the contralateral eye resulting in swelling. So the pathogenesis has to do with transient insufficiency of blood flow to the optic nerve related to the posterior ciliary arteries and the peripapillary choroidal artery. And this is related, as we talked about, the vasculopathic risk factors of systemic microvascular disease, this crowded optic nerve head, and nocturnal hypotension. Hay-Ray studied the optic nerve head and found a number of interesting and important findings. One, that there's between 1 and 5 posterior ciliary arteries that are located around the optic nerve head, and these branch into long and short PCA. Importantly, there are watershed zones between these posterior ciliary arteries, and these watershed zones are what explain these segmental disc swelling. Hypoperfusion of the PCA. Most commonly, these watershed zones are located on the temporal and superior part of the disc. That's just how these blood vessels happen to be arranged, and that's why we get this generally superior disc swelling resulting in an inferior visual field defect. There's really not a lot of evidence for embolic or vaso-occlusive events, and so those have been mostly put to rest as a cause for ION. The natural history is that a fair number of patients, maybe about a third, will have some visual improvement over about 2 years after their event. But, about 20% may actually have worsening of vision by about 3 lines at 2 years. There's not a lot of change in the visual field over time. It's really the visual acuity that tends to change. And we know that patients with vasculopathic risk factors fared worse. Edema is a common question my residents ask, resolves in about 6 to 11 weeks. These patients tend to develop pallor but not cupping, which is a little bit different from arteritic ischemic optic neuropathy, which is more likely to develop cupping after time. Second eye involvement was also studied in a number of series, between 30 to 40% in some series, although the decompression study found it in only 15%. But still, that's an important thing to discuss with your patients as to why we have to control the risk factors to prevent second eye involvement. Sequential same-eye ION is actually not very common, and one of the reasons is we think that the atrophied part of the nerve allows a little bit more room for nerve swelling should there be a second ischemic event. The important systemic factors are transient ischemic TIA, stroke, and MI. And for that reason, any patient who presents with ischemic optic neuropathy should be referred to their primary care doctor for a full physical exam. A number of medicines have been looked at over the years to try to treat this condition, including neuroprotective agents, antithrombotic agents, vasodynamic medications. One quick word about vasodilators. We are already concerned about nocturnal hypotension and hypoperfusion of the nerve, and so these should probably not be considered at all in these types of patients. And other agents like erythropoietin, brimonidine, anti-VEGFs, hyperbaric oxygen. But the one thing that I do want to speak about in a little bit more detail is steroids. And I think a lot of us have considered and maybe even give steroids to patients with ischemic optic neuropathy. And one of the studies that is commonly cited as the reason for doing this is this study by Hayray from 2008 that looked at the use of systemic corticosteroids. And the conclusion from this study was that both visual acuity and visual of fields improved up to 6 months after the onset of these symptoms. However, we should take a little bit of caution because this was not level 1 evidence. It was in fact a patient choice study where the patient decided did they want steroids or not. There was no masking of the patient or physician. And when we looked at the patients in the study, there actually were more diabetics in the untreated group than the treated group. And therefore, did those patients do worse because they were sicker? Ultimately, I think there's a little bit concern for bias in this study, and we should be careful drawing conclusions based on this study in terms of the use of steroids. The decompression study, which we discussed about, provided important baseline characteristics that help us understand how these patients might fare, was really designed to study will this intervention help these patients and their vision? And it turns out that it was not effective or harmful. And this was determined at the interim analysis of the study. At the interim analysis, it was observed that the intervention was not effective because the patients who were observed ended up with better vision than the patients who had surgery. And in fact, maybe this intervention is harmful because the patients who observed were less likely to lose vision than the patients who had the surgical intervention. So at the interim analysis for this study, it was determined that this is not effective, may be harmful, and the study was stopped early. So to date, there's still no proven treatment. We tell our patients to manage the vasculopathic risk factors, evaluate for sleep apnea, but there is one ray of hope. There is an ongoing clinical trial that was partly based on that data that I showed earlier about 20% of patients who may have progressive vision loss. And there's some thought that there's a role of apoptosis that can cause this progression of vision loss. These patients have been found to have elevated caspase levels, and caspase is a known propagator of apoptosis. And so can we block this caspase and therefore prevent this further vision loss? And that's what this study aims to find out. This is a prospective randomized placebo-controlled multi-center study, 530 patients of an intravitreal injection of a caspase inhibitor to find out the proportion of patients who lose 15 letters or more of best corrected visual acuity. So this is the largest ION study to date, 8 countries including India. Important referral criteria that you should consider are, all have to be patients age 50 to 80 with sudden vision loss in the last 14 days, and this is one of the most important criteria, but also one of the things that limits some of the referrals, because a lot of physicians feel there's no treatment for ION, so they don't expedite the referral. But for this study, we have to think very carefully about that, because they're excluded if they're after 14 days of symptom onset. And they cannot have had any prior treatment for this vision loss, including steroids and bromonidine. Those are both exclusionary. These are the 12 sites in India, which can also be found on this registry. In summary, ION is the most common cause of unilateral optic neuropathy in patients over 50. In India, patients may be a little bit younger than in the US. The pathophysiology is related to the watershed zones from the microvasculature. Remember the natural history, 30 to 40% will have visual improvement, but 20% may have worsening of vision. And because there's no proven treatment, there's a very important clinical trial ongoing. Please consider referring your patients. Thank you.
Thank you, Dr. McIntosh. If anybody is having any question regarding AION, then they can ask from Dr. McIntosh or about the trial.
Yes. It was a fenestration, an optic nerve sheath fenestration. Thank you.
No, if the next session chairperson is here, then they can just take the dais and
I thank all the speakers of the last session. Thank you so much for concluding the session on time. Thank you.